All right, so know most of you or many of you, but for those of you who don't know me, I'm Nicole Cipriani. I am a surgical pathologist with a very strong interest in head and neck and thyroid pathology. I also do bone and soft tissue pathology, so I work closely, of course, with all of the ENT department, with the endocrine surgeons, as well as with orthopedic surgeons. Some of you guys have been rotating through our sign out service, which I think has been great, both, for our education to learn from you clinically and hopefully for yours to learn from us histologically. So we're really excited that we're doing that. Please, if you have any questions along the way, feel free to unmute yourself or just type something in the chat. I will have that open. I tried to find some topics that may be more high yield for you guys. So today I'm going to do thyroid and parathyroid, and next session I'm going to do salivary. I have some additional lectures on other topics, which in the future I'd be happy to give as well. But for those of you who haven't seen my presentations yet, for those of you who are new, I'm going to just go briefly through an overview of surgical pathology processing, how your specimens get processed when they come to us. I'm going to review then the workup of thyroid nodules. We're going to talk about cytologic features of thyroid FNA, as well as how they correspond to histologic diagnoses. We will identify commercially available molecular tests, which are now becoming very important for thyroid FNA in order to understand their utility in guiding surgical management. We're going to talk a little bit about what happens to your thyroid once it comes to the gross room and why some things we do are meaningful. And if we have a chance, we'll talk very briefly about para. There's the link to my other YouTube videos, so you guys can feel free to please look at them if you need to. So when a organ gets biopsied or surgically removed, it of course comes to the gross room, where we do an examination both grossly and microscopically. So we basically end up cutting the organ into smaller pieces to examine on the slide. We may perform special studies like immunostains or molecular testing. We of course render a diagnostic report, which goes back to affect treatment for that patient. So on gross exam, we essentially take serial cross sections through a specimen. In this case, we have a cross-section through a thyroid lesion showing sort of normal reddish thyroid on the top and bottom, with, of course, a very white, irregularly shaped lesion in the middle. We take small sections for histologic exam. So as you can imagine, we don't examine every inch of this specimen. We have to be selective, excuse me, with our sampling. So histologic sections are taken for every specimen, with the exception of those that you perhaps request as gross only, which doesn't happen very often. Things like teeth, we don't routinely process. Things like, for example, benign tonsils, we do routinely process, except if you ask for an exception. Like, please don't only do a gross exam. I don't want to charge the patient for histology. They're 2 years old. There's nothing in there. Fine, we'll honor that. Otherwise, everything gets sections. So how does this tissue get turned into a glass slide that we can examine under the microscope? Basically, those sections the size of about a nickel are placed into these plastic cassettes. They are essentially fixed in formalin, processed in a number of substances that essentially dehydrate the tissue, which that processed and fixed and dehydrated tissue is essentially embedded in a paraffin wax block, which makes it easier to cut on a microtome by our histotechs. These slices are cut on a microtome at about 3 to 5 microns, placed on a glass slide and stained. So if you can imagine, a red blood cell is about 7 microns. These are about half that width. So even this tissue that we put in the cassette, even only a small fraction of that tissue is examined, because these slices are maybe 2 to 3 millimeters in thickness, and this is only 4 microns. Every single slide gets a standard H&E stain, hematoxylin and eosin. So hematoxylin is a basic or an alkaline dye. It binds acids in tissues, such as nucleic acids. And so hematoxylin, being a blue dye, essentially turns those acids blue, or so-called basophilic. Eosin is an acidic dye, so it binds the bases in the tissue, which are mostly located in the cytoplasm. And in this case, The tissue is so-called acidophilic or eosinophilic. The eosin is more of a pink stain. We also do immunohistochemical stains, which detect very specific proteins, right, in the cytoplasm or the nucleus or the cell membrane. These are, of course, antibodies, which bind to very specific proteins in the cell. They're conjugated to dyes, usually brown or red. There's always a counter stain placed on the tissue just so we can tell like what's going on in the background. So in this case, you see a brown cytoplasmic reaction with a blue counter stain. Here you see a brown nuclear reaction, again with a blue background counter stain. Occasionally, we also do histochemical stains that bind general types of chemicals and biologic structures, not specific proteins. Examples are GMS that highlights fungal cell walls. Examples are Congo red that highlight amyloid. And examples are also mucicarmine, which highlights all various types of mucin. Okay, so that's general processing. We'll move on to thyroid. So the thyroid has, of course, the follicular cells and the C cells. Follicular cells develop as a condensation of endoderm at the base of tongue, at the foramen cecum. They migrate down the neck in the anterior midline, of course, via the thyroglossal duct. The thyroid then solidifies into the right and left lobes connected by the isthmus, lying across essentially the upper trachea. Sometimes a midline pyramidal lobe, as you know, can remain. However, sometimes the thyroglossal duct, of course, may also persist, and sometimes it becomes cystically dilated, hence a thyroglossal duct cyst. The C cells, on the other hand, were originally thought to develop from neural crest. However, it was recently shown that they actually developed from the pharyngeal pouch system, specifically the fourth pharyngeal pouch or the ultimobranchial body, literally the ultimate branchial, the last branchial structure to develop from that pouches. The cells fuse with the thyroid gland. So both the C cells and the ultimobranchial body, essentially squamoid cells, merge and disseminate into the thyroid, mostly at the upper to mid poles of the gland. So it's the upper to mid pole where you'll see your medullary carcinomas, because that's where the C cells are. And here's a histologic example of normal thyroid showing follicular cells on the left and C cells on the right. So follicular cells, of course, form these essentially balloons called follicles, where the nuclei are very small, very round, very dark, very regular. You can see them on the bottom left. C cells are not normally visible under light microscopy. In the normal state, if you see them, they're probably hyperplastic. So this is an example of C cell hyperplasia. You can see there is a single residual follicle here on the left, but the remainder of this tissue is involved by a proliferation of these more solid nests of cells that have this kind of granular cytoplasm, because these do contain neuroendocrine secretory granules. And this kind of, again, dark salt and pepper, maybe less salt here, but more pepper chromatin. So those are the C cells. Follicular cells stain with markers of thyroid origin, in case you're interested, such as TTF1, PAX8, thyroglobulin. C cells, of course, will stain with neuroendocrine markers like synaptophysine chromogranin and calcitonin, which, of course, they secrete. When thyroid nodules are identified, how does that happen, right? So most studies estimate that over half of the general population has thyroid nodules. So extremely common, mostly benign, but of course, occasionally malignant. And so if large enough, they can be identified by palpation or visualization by the patient themselves, as seen on the bottom right, palpation on the physical exam by yourselves or other physicians, as well as, of course, imaging of the neck that may be done for other reasons, other cancers. A thyroid nodule pops up and it needs evaluation. So of course, the first step in the workup is just ultrasonographic examination. Is this nodule ultrasonographically low risk or ultrasonographically more high risk? If more high risk, this patient may undergo fine needle aspiration biopsy, which is the standard of care, not core biopsy. Although, as we see, some institutions in the surrounding neighborhoods do perform core biopsies, which make it much more challenging to evaluate. FNA is much better for diagnosis. We prefer ultrasound guidance over just manual palpation guidance, especially if the nodule is smaller, because then you know you're targeting the nodule of interest. However, if the nodule is large and palpable, occasionally palpation alone can be performed. So the American Thyroid Association has come up with radiographic features that place nodules at higher versus lower risk for being malignant. So of course, microcalcifications, irregular borders make something more high risk. Regular borders with spongiform features make something very low risk, and sort of cystic hypoechoic would be very, very low risk benign. So depending on these features, these ultrasonographic features help determine the need for an FNA biopsy depending on features as well as size. Once a biopsy is performed, the cytologic features on FNA essentially help determine the need for surgery, whether it be benign, indeterminate, or malignant nodule. And then, of course, the histologic features after resection determine the final diagnosis. So the goal of preoperative FNA is to differentiate benign from malignant to guide therapy. So something that's benign and asymptomatic can certainly undergo observation. If it's symptomatic, however, these patients may undergo resection despite being benign, just for symptomatic relief. And of course, if something is malignant and essentially over 1 centimeter, it will likely undergo resection. But not all FNAs are obviously benign or obviously malignant, and this is where the indeterminate categories come in. So the so-called Bethesda system sorts thyroid FNA into categories with increasing risk of malignancy. And these have both numerical as well as verbal descriptive categories ranging from 1 to 6. So 1 is unsatisfactory, meaning I didn't get the lesion, probably rebiopsy is going to be required. 2 is essentially benign, a colloid nodule, a cyst, even lymphocytic thyroiditis. 3 is atypia of undetermined significance or follicular lesion of undetermined significance, which is defined by rare cells, but either nuclear or architectural irregularities. 4 is suspicious for follicular neoplasm, so very cellular. 5 is suspicious for malignancy, and 6 is malignant. And so 3, 4, and sometimes 5 are considered indeterminate and may benefit from molecular testing on FNA, which we will get into very much more later. Here is the listed Bethesda rates or risks of malignancy from each of these categories compared to the University of Chicago rate or risk of malignancy, which very much is on par with what is sort of expected in the general population. So of course, in the case of the indeterminate nodules, the patient has a few options to either undergo molecular testing on FNA, to undergo surgery for definitive diagnosis, i.e. diagnostic lobectomy, occasionally to undergo repeat biopsy. But once you have an indeterminate biopsy in your chart, it's very hard to get rid of that with a benign diagnosis. But sometimes you may solidify it with a malignant diagnosis. So patients who undergo lobectomy are those that will require definitive diagnosis of an indeterminate nodule or treatment of a low-risk carcinoma that does not need radioactive iodine therapy. Those who undergo total thyroidectomy are those that require symptomatic relief for non-neoplastic diseases like multinodular goiter, hyperplastic Graves, Hashimoto's, et cetera, or treatment of higher risk carcinomas that do need radioactive iodine ablation and therefore do require a surgical removal of all thyroid tissue. So first, we're going to start with some cases that will correlate the cytologic features on FNA to the histologic features following surgical resection. So we're going to be talking about both the benign, the indeterminate, and essentially the malignant lesions. So I don't have the diagnoses up here yet because as I describe them, I want you guys to think about what this could be. So this is a sheet of very bland follicular cells. You can see it almost has a honeycomb pattern with very well-defined cell borders. Here the nuclei are very round and regular. And this watery kind of greenish material in the back is abundant colloid, with this field only showing scant follicular cells. So both these large sheets that are torn off of a large follicle and this abundant colloid are both diagnostic essentially of a benign lesion, such as a so-called colloid nodule. And I'll go through the histology of these subsequently. So what does this look like on resection? You might imagine that the follicles in this case of a so-called benign macrofollicular adenomatous nodule or colloid nodule, the follicles are very large, right? And so those sheets that you saw torn off right here are essentially the sides of these very large balloons that you see on FOSS. And of course, the nuclei remain small, dark, round, and regular. These tumors can either be well circumscribed or truly encapsulated. In this case, this is unencapsulated but circumscribed. Grossly, these look very kind of gelatinous because of those large follicles filled with colloid. This generally corresponds to a so-called benign colloid nodule on FNA, but the histologic diagnosis may vary from adenomatous to colloid to hyperplastic, depending on the preference of the pathologist, but essentially benign. So why do we use the term adenomatous? It's because these nodules can either be truly clonal neoplasms, i.e. adenomas, or hyperplastic lesions, but this distinction between neoplastic and hyperplastic cannot necessarily always be made histologically. It can only be made on genetic analysis, such as by finding a mutation or by determining clonal X inactivation, for example, in females. So because it doesn't really necessarily matter for the patient, we call it adenomatous to not have to make the distinction between a hyperplasm and a neoplasm. The hyperplasia, if it's a functional hyperplasia, of course, will come out clinically, right, with hyperthyroidism. Otherwise, we cannot tell histologically. All right, next case. This is a case on the left where you see these clusters of cells that have kind of abundant but ill-defined cytoplasm with these large nuclei. Sometimes the image on the left is a diff-quick smear. The image on the right is a pap smear. The other thing you identify in the back, so the things I'm highlighting here are the clusters of true thyroid follicles, but these small discohesive cells in the background are lymphocytes. So in this case, we have some oncocytic cells with some lymphocytes in the background, and this is characteristic of Hashimoto's or lymphocytic thyroiditis. So this is also essentially a benign diagnosis. Sometimes Hashimoto's thyroiditis develops these prominent nodules, but they're not actually neoplasms, they're just nodular thyroiditis. And so you can see here on cut surface, these vague nodules. You can see histologically that there are these very blue areas of lymphoid inflammation with these paler white germinal center, or paler pink germinal centers, I should say. The other characteristic change in Hashimoto's is oncocytic change of follicles in the inflamed areas. I'll show you what that means more closely on the next slide. So oncocytes, or so-called Hürthle cells of the thyroid, are cells that have abundant eosinophilic granular cytoplasm because they're full of mitochondria. You can see on these electron microscopic images on the right. They have large round nuclei with very prominent nucleoli, as seen here, because they're very metabolically active. In the thyroid, they are called Hürthle cells, but they can also be seen in other organs. You can see oncocytes in parathyroid, in kidney, and in salivary gland, in which they are not called oncocytes, in which they are not called Hürthle cells. They're just called oncocytes or oxyphil cells. But essentially, the histologic appearance is the same. In thyroid, they are Hürthle. All right. Moving on. Of course, if you guys have questions, please type them in or chat them out. This is a case of some sheets of cells that have, again, honeycomb appearance with very bland, round nuclei, or very, very rare groups that show nuclear grooves and membrane irregularities, but these clusters are very, very rare. And so even though there are some sort of, bland looking areas, the presence of these clusters of cells with nuclear atypia essentially negate it from being in a benign category. And so this is one of these indeterminate categories called AUS, atypia of undetermined significance, which is predominantly rare clusters with nuclear atypia that are suspicious or worrisome for papillary carcinoma, but not really showing all of the features. This is a second example of another specimen that is also paucicellular, but you see these rare microfollicles. So rather than these flat sheets of cells, the cells are clustered into these almost rosette-like structures. You can imagine how if you pluck this out of a patient, this would actually be a very, very small follicle. The nuclei themselves are round and regular, but the shape and size of the follicle is too small. So this is called FLUS, follicular lesion of undetermined significance, which is essentially this architectural irregularity. The next FNA case we have, on the other hand, is actually very cellular, unlike the prior two that were paucicellular. This is full of cells. It even has these long strands are actually vessels. So these are essentially capillaries. You see the endothelial cells. So this is a very vascular lesion. And then you see also these clusters, sheets of cells, perhaps microfollicles if you look closely. But again, the nuclei are very round and regular. They don't have nuclear atypia, but it's just way, way, way too cellular for a colloid nodule, for example. So this is called follicular neoplasm, or suspicious for follicular neoplasm, because of the high cellularity, but the bland nuclei. So looking at these three categories of AUS, atypia of undetermined significance, which we find to be nuclear atypia, FLUS, follicular lesion of undetermined significance, which are occasional microfollicles, and suspicious for follicular neoplasm. At the University of Chicago, our malignancy rates for these three categories are very, very low for FLUS. So a FLUS diagnosis in this institution generally tends to be a benign adenomatous nodule. AUS, nuclear atypia, has about a third risk of ending up as papillary carcinoma, and suspicious for follicular neoplasm, that very highly cellular one, has about a quarter chance of being malignant. In this case, both either papillary carcinoma or follicular carcinoma, depending on what we see on histology. So, you know, these features that we see are on FNA are quite meaningful for what we might expect on resection. That being said, you know, less than, right, it's still a relatively small percentage, FLUS being the smallest, AUS and SFN being slightly higher, but less than 50% risk of malignancy for all of these cases. All right, and so what you might see on resection, generally of something called a FLUS or a follicular neoplasm on FNA, would be a well-circumscribed nodule. Sometimes it may have a capsule. In this case, we actually do see a pink fibrous capsule. The follicles in this case are small, smaller than the regular thyroid, which we see up on the top, hence micro, right? So when we saw that FLUS with those little rosettes or microfollicles, it was recapitulating what we see histologically as these very small follicles with only scant colloid in the middle. But still the nuclei remain dark, round, and regular. So this does not put us in the place of a PTC, but this puts us in the place of a follicular neoplasm, which may be diagnosed as either microfollicular adenomatous nodule, small follicles, or just follicular adenoma. Grossly, these tend to be more solid and white, but have very well-defined borders. Of course, your differential diagnosis with a follicular adenoma is going to be something like a follicular carcinoma. And there are a few small ways to diagnose follicular carcinoma, one of which is capsular invasion, in this case showing the very classic so-called mushrooming invasion through the capsule, where the tumor no longer respects the geographic boundaries of its edge. The second way to diagnose follicular carcinoma is vascular invasion, and this is usually in sort of medium caliber blood vessels, either in the capsule or adjacent to the capsule. So here you can see the tumor below and these large plugs just filling the vascular spaces. On higher power, here are the follicles that are essentially lined by endothelium, showing fibrous adherence to the vascular wall. This on the left here is the wall of the vessel. And so this is not a lymphatic vessel, right? This is a blood vessel, usually of venous caliber. And this will predict the patient being at risk for hematogenous metastases to places like bone, lung, brain, or other visceral organs in the body. So these are the ways we diagnose follicular carcinoma. Oops. All right. Moving on to a similar yet slightly different bird. This is an FNA, also very cellular. And rather than showing characteristic follicular cells, this is actually showing clusters of oncocytes. How do we know they're oncocytes? Again, because The cytoplasm is very abundant and granular, and the nuclei are large with prominent nucleoli. I think this image on the left shows those features very well. The left is a pap stain and the right is a Diffquick. The nuclear features on Diffquick are not quite as appreciable, but what you can see on Diffquick is the abundance of the cytoplasm and the somewhat variability in shape and size of the nuclei, which you can also see on the left, right? Some nuclei are small, some nuclei are larger. That's actually quite normal for oncocytes. So we're not going to let us get bothered by that. So this is essentially a Hürthle cell neoplasm because of the cellularity and the oncocyte-rich features of the cells. So this might be something that ends up being a Hürthle cell or an oncocytic adenoma. These are thought to be somewhat genetically different than non-oncocytic follicular adenomas, as in they have more mitochondrial DNA mutations and somewhat lower rates of RAS mutation. We'll get into the genetics a little bit later, but on higher power, you can see how these cells are essentially all oncocytic with very prominent nucleoli, pink cytoplasm. So this is a Hürthle cell or oncocytic adenoma. But of course, the differential diagnosis here would be a Hürthle cell or oncocytic carcinoma, again, where capsular or vascular invasion would be crucial for making a diagnosis of carcinoma. And so my nice blue dots here highlight for you the fact that there are these tongues of cells that are on the opposite side of the capsule. That is diagnostic of follicular oncocytic carcinoma. But you can see the cells here are still oncocytes, very, very pink cytoplasm, a little bit of nuclear size and shape irregularity, totally normal for oncocytes. Okay, if there are no questions.
Dr. Cipriani,
Yep.
I had a question.
Yeah.
Hey, so if we see Hürthle cells on a slide, does that mean the patient has cancer for sure? Like, are these oncocytes diagnostic for either a neoplasm or carcinoma, or are they normal cells also?
They are neither normal nor diagnostic of carcinoma. So
Or adenoma. I mean, like benign or, but like
so,
are Hürthle cells themselves seen in normal thyroid?
so they can be seen, as I maybe briefly mentioned, in inflammatory states like Hashimoto's.
Okay. Okay.
Yeah. So in Hashimoto's, they are what I would argue is more of a metaplastic change that happens in response to the inflammation. And so sometimes the entire thyroid is just full of Hürthle cells, but it's not mass forming, right? And so in that case, you'd have to take into context, are there additional lymphocytes? Is this a mass forming lesion? Is this an inflammatory state, right?
Okay. Makes
Versus,
sense.
yeah, is this a mass forming lesion? If they are Hürthle cells in a mass forming lesion, right, then it's either an adenoma or a carcinoma.
Cool. Awesome. Thank you.
No problem. Okay. Moving on to our next FNA, which hopefully I think you'll see the direction in which I am creeping. So this is also a highly cellular smear. You can see these very large clusters and these smaller nests. And you may be able to vaguely make out that in an area like this, for example, do I have see if I can draw here. Oh yeah, there we go. This might almost look like a little staghorn, like a papillum. This might look like a little structure or a papillum sticking out. So we're starting to see some architecture that's not just sheets or follicles. We're starting to see things that look like, maybe architectural papillae. On the right, again, we see a cluster of cells that has very well-defined cell borders. You can very much make out where each cell ends and begins. And the nuclei are somewhat irregularly shaped and sized. All right, and then moving on. Oops, come on. Oh, I need my mouse back. There we go. Okay, on higher power or on a pap smear, which is what you see here, you may also end up seeing very characteristic nuclear features. In this case, pseudo-inclusions. So what am I talking about? So I'm talking about the fact that this nucleus has an outer nuclear membrane, right? It has some blue chromatin. It also has an inner nuclear membrane, and then it has some more paler material in the center. And if you look, this paler material in the center resembles the characteristics of the cytoplasm on the outside of the cell of the nucleus, right? So this is an intranuclear cytoplasmic pseudoinclusion. You see one here, right? You see one here, you maybe see one here, maybe one here. So these are diagnostic of everyone's favorite papillary thyroid carcinoma. So in this case, the FNA is in fact not an indeterminate diagnosis. This is a definitive diagnosis of a PTC. And so on histology, what you'll see is generally an infiltrative neoplasm. Infiltrative meaning it percolates out into the normal thyroid and or demonstrates stromal fibrosis or desmoplasia. You can see here these large pink irregular bands. Here again, pink irregular band, with prominence of papillae. So you can see these large structures here. These, again, recapitulating that sort of staghorn branching pattern that we saw on the FNA, right? These are papillae, and these are papillae. Seen on higher power, you can see a papillum cut in longitudinal section, and you can see a papillum cut in cross section. These papillae have fibrovascular cores lined by, of course, malignant papillary epithelial cells. Here you can see the pseudoinclusions on histology with, again, that characteristic cytoplasm in the center. And if you're lucky, you may see a psammoma body, which is a concentrically lamellated calcification, which is thought to be the ramification of perhaps an infarcted papillary tuft. Interestingly, we can also see psammoma bodies in carcinomas that have papillary morphology in other organs, like serous carcinoma, papillary serous carcinoma of the ovary also has psammoma bodies. So it's perhaps related to the architecture and the cellular infarction that occurs with papillae. All right, now I lost my mouse. Okay. All right, so why do papillary carcinoma nuclei look the way that they do? So it's thought that the nuclear membrane surface area perhaps increases and it has no place to go. So then it folds in on itself and it forms a groove or sort of a coffee bean shape. If it pouches very far into the nucleus as sort of like a cup, it can form this indentation. If the indentation is cut in the appropriate plane and the indentation is deep enough, it now creates the appearance of a pseudoinclusion. So it's essentially an intussusception or invagination of the cytoplasm into the nucleus that, when looked at in the appropriate plane or cut in cross section, looks like a hole of cytoplasm in the nucleus. This is different from the chromatin margination or chromatin clearing of a so-called Orphan Annie eye. So why Orphan Annie? So in the old cartoons, right, Orphan Annie and her dog had these very dark lines around the eyeballs with very white centers. And so this is what these cells look like, right? They're white in the center because there's nothing. There's no chromatin, there's no cytoplasm, it's just void of anything. And the chromatin has marginated to the periphery of the nucleus. This is different, right, from a pseudoinclusion, which is actually cytoplasm falling into the nucleus. Okay, so these features are, as well as the architecture, are what helps make papillary thyroid carcinoma diagnostic on cytology. All right, just to review, we saw follicular carcinoma and we saw papillary carcinoma histologically. Just to review, papillary is certainly the most common and increases in risk with radiation exposure. Follicular carcinoma is considered next most common and may be related to iodine deficiency, and especially in some areas of the world that are lacking in iodine. Most thyroid disease, both neoplastic and non-neoplastic, as you may know, occurs in women of various ages. Papillary is defined by both papillary architecture as well as those atypical nuclei. Of course, follicular is defined by mostly follicular architecture, but with vascular and capsular invasion. And quite specifically is actually the genetics. So the genetics of papillary and the genetics of follicular carcinomas are essentially mutually exclusive, which can be very helpful for us when trying to diagnose tumors that are kind of on a histologic border between the two. BRAF V600E mutation is found in a high percentage of papillary carcinomas, RET PTC or other gene rearrangements in a smaller percentage. RAS mutation is found in a high percentage of follicular. I would argue it's probably even more than 40. Sometimes PAX8 PPAR gamma rearrangements. Prognosis in papillary is related to both age as well as soft tissue invasion and lymph node and or distant metastases. But as you know, PTC spreads very commonly to lymph nodes, but survival and prognosis in these patients is still quite good. It's well responsive to radioiodine usually. Survival is excellent. In follicular, once these are out of the thyroid or so-called out of the box, these are the ones that behave worse. So minimally invasive, restricted to the thyroid, usually these patients have well survival, but those that start to widely invade, survival drops. All right, any questions before moving on? We'll go more detail in the molecular in a bit. Okay, so another example, slightly different. You can see how these cells on FNA are a little bit more spindly or fusiform, not quite as plump as the others. You might see, in fact, a chunk here of stromal amyloid. You may see here on the top right, very granular cytoplasm, maybe even binucleation. So these features are actually also diagnostic of medullary carcinoma. So medullary carcinoma is another diagnosis that we can make on FNA. This, of course, is the calcitonin secreting tumor composed of the C cells or neuroendocrine cells of the thyroid. Even though this has a somewhat defined border, these are always essentially considered infiltrative neoplasms. They have very granular cytoplasm. Here, nice showing salt and pepper chromatin, characteristic of neuroendocrine type cells. I guess what I don't have pointed out here is that this very eosinophilic stroma in the background is amyloid, which stains with Congo red. It is different than the amyloid that you see in like, multiple myeloma or plasma cell lesions. It's actually polymers of calcitonin. So this is stromal deposits of calcitonin that is organized in a regular fashion and does pick up Congo red. So medullary carcinomas are a small percentage of all thyroid malignancies, and familial medullaries are only a quarter of all medullaries. The familial ones tend to be multifocal, tend to occur at younger ages, and certainly these patients will have RET germline mutations. However, even in a theoretically sporadic case of medullary carcinoma, which is thought to be the majority of medullaries, these tend to be unifocal and these tend to be in older patients. Even with sporadic medullaries, these patients should at least get tested for RET mutation in the tumor. If a RET mutation is present in the tumor, then the patient should be tested for RET germline mutation, because sometimes an incidental familial syndrome is picked up based on an older age of diagnosis. And so just be careful with medullary patients and have a low threshold for doing the mutational analysis. If the tumor itself is negative for a RET mutation, then there's no way the patient has a germline RET. So that's at least safe. Okay, but medullary can metastasize both to lymph nodes as well as to distant visceral organs. Okay, moving on. This case has cells that are somewhat more large and pleomorphic with very irregular nuclei, very like almost cherry red prominent nucleoli. Here on the left, the cells are very hyperchromatic. The nuclei are very dark and overlapping. And so what I'm trying to get here is that, there are also other diagnoses that rather than just the standard, follicular neoplasm, papillary, medullary, we always have to think about additional, more aggressive diagnoses in thyroid. And so if the tumor remains of follicular cell origin, the options we have for more aggressive thyroid carcinomas are both poorly differentiated as well as undifferentiated. Poorly differentiated, as you can see on the left, still somewhat resembles thyroid follicular cells, but the architecture is effaced. There is really no evidence of follicles, no evidence of papillae. These are sheet-like growth with diffuse broad-based invasion into the surrounding thyroid. You can see on the bottom left here, the sheet-like growth. I'm going to highlight one mitotic figure, and I'm going to highlight here with my mouse this area of punctate tumor cell necrosis. So poorly differentiated carcinoma is that of a solid tumor with increased mitoses as well as necrosis. Anaplastic carcinoma or undifferentiated carcinoma no longer looks like thyroid. It looks ugly. It looks like a high-grade undifferentiated carcinoma. It looks like a high-grade sarcoma. And so, but clinically, right, these are very locally aggressive in the neck. These present with, essentially patients, of course, having stridor, having difficulty breathing, essentially suffocating, with lots of invasion into the larynx and or trachea. And so both papillary and follicular can transform to poorly diff. Both papillary and follicular and poorly diff can transform to anaplastic. And median survival for poorly diff and anaplastic tends to be on the number of years or decades to essentially months for anaplastic in the worst cases. But to review, each of these thyroid cancers has mutations that tend to be kind of specific to each of them. So the follicular neoplasms, right, the follicular adenomas and carcinomas tend to have RAS mutations, H, N, or K. They can have BRAF mutations, but these are the non-V600E BRAFs, like the K601E. They can also have the PAX8 PPAR gamma fusions. But in this case, benign and malignant have the same molecular profile. Therefore, we can't tell benign or malignant adenoma carcinoma by just the genetics. That is different from papillary carcinoma, where if you have any one of these, you are essentially a PTC. That would be a BRAF V600E, a RET PTC fusion. Things like NTRK fusions or even other BRAF fusions are thought to also be papillary. Once you start getting compounding more aggressive mutations like TP53 or TERT promoter, that puts you at higher risk for being poorly or undiff. And then as we talked about, medullary is in its own sort of category. These are RET mutations. Remember, this is different from the RET PTC rearrangement found in papillary. These are RET point mutations. But not every single thyroid tumor harbors a known genetic driver. There's still this sort of dark matter or unknown, but many tumors can be placed into categories with these genetics. This is why molecular testing on FNA has been quite useful. And so now knowing what our diagnostic options are and what our mutational profile is, we can take a little bit of a deeper look at these molecular tests. So there are 3 commercial tests for so-called indeterminate cytology in the United States. Again, the indeterminate being Bethesda 3, 4, and sometimes 5. The 3 companies are Veracyte's Afirma test, Interpace's ThyGenX and Thyromere, and ThyroSeq. We at this institution sent to Interpace for reasons that are, they're all okay, but Interpace was preferred because they do not require temperature stabilization of their media. So both Veracyte and ThyroSeq require the medium to be refrigerated or frozen. Interpace does not, so that's much easier for storage. Interpace can also do the testing off of both cells in their medium. They can do it off of formalin fixed paraffin embedded cell blocks, and they can also do it off of cytology smears. So much wider range of testing capabilities for that company. So regardless, all of them have essentially two tests that they perform. Veracyte, Interpace, and ThyroSeq all have a messenger RNA or a microRNA gene expression profile that sorts nodules into those with gene expression profiles that are more commonly seen in benign neoplasms versus more commonly seen in malignant neoplasms. Those are not single gene mutations. That is just a background expression profile. The second thing that they all have are these single gene mutations or single gene fusions that are present in thyroid neoplasms, but as you know, some may be specific to malignancy and some may not be. So you can see here in the red and the green, all of these offer the same, essentially the same findings. So if you get a negative gene expression profile with no mutations or fusions, your risk of malignancy in all of these tests is very low, 4 to 5%. So a negative test in all of these three is very helpful to rule out malignancy and to avoid surgery, right? So you've essentially taken a cytologically indeterminate nodule and basically put it in a molecularly benign category. The challenge is when you have a so-called positive or a suspicious result. And the outcomes of a positive or a suspicious result are highly variable. So because Veracyte's Afirma was one of the first and is one of the more commonly used out in the community, I just wanted to alert you to their terminology. Their terminology is either sort of negative, benign, or suspicious. So suspicious doesn't actually mean you have a high risk of being suspicious for malignancy. It basically means not benign, right? So if they just have a positive gene expression profile and no specific mutations, that quote unquote suspicious still puts you at a coin toss, like 50% malignant, right? So suspicious isn't what we think of as like very high risk of malignancy. It's still kind of indeterminate. So I'm just cautioning you about their wording. If you do find something like a BRAF V600E, a RET PTC, a RET point mutation for medullary, those are the cases where you actually can pretty much say that the patient has cancer. However, if you find something like a RAS mutation, right, which we know is present in follicular neoplasms, then you are still a little bit more variable. You're still at a neoplastic level, but we still don't know whether you're carcinoma or not. So I would just argue that a positive result on any of these molecular tests is highly variable and depends on what is identified. So I would urge you to read very carefully these reports to determine, is it the gene expression profile alone that's positive? Is there a specific mutation or fusion that can point you to a carcinoma or a neoplasm? Because that might at least inform your thought process on this patient. So to recap, a negative mutation and a negative expression profile is essentially a benign nodule with risk of malignancy now being very low, less than 5%. These patients do not have to undergo surgery unless there are other indications for them to get operated. A positive mutation in the follicular neoplasm spectrum, like a RAS, a BRAF non-V600E, or a PAX8 PPAR gamma, can be a follicular adenoma, can be a follicular carcinoma, can even be something like a NIFT-P, which I apologize we didn't talk about, but we can get into that if you guys like. These patients will still require diagnostic lobectomy for definitive diagnosis. If you find a positive mutation that is indicative of carcinoma, like BRAF V600E, RET PTC, NTRK fusion, BRAF fusion, RET mutation for medullary, perhaps even an aggressive like TP53 or TERT promoter, these may undergo either therapeutic lobectomies or therapeutic total thyroidectomies, depending on the indications, but certainly they will require surgery. Lastly, if you have a negative mutational profile, but a positive gene expression profile, the risk for carcinoma still remains. These patients will still require some kind of diagnostic lobectomy for definitive therapy. So these are the 4 categories I tend to put patients in after they come out with molecular testing. Do you guys have questions on this? I think the reports of these companies are getting much more sophisticated in terms of how they're reporting all of these mutations and fusions. So always take into account what they're finding, which will guide your knowledge of what underlying disease that patient may have. So in the last, 8 minutes or so, I can get into some more things that happen behind the scenes in our growth lab, or I can talk, which we didn't yet, about NIFT-P. So you guys tell me what you want to hear.
NIFT-P, please.
NIFT-P, okay. All right, so let me stop my share for a second and find a different file very quickly. All right. Okay. So let me just move forward a little bit. So here we go. All right, so NIFP stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. The original diagnosis of a lot of what was called NIFP was I'm going to move back, the follicular variant of papillary thyroid carcinoma. So the follicular variant of papillary thyroid carcinoma was originally described in the 60s and 70s as being biologically very similar to papillary carcinoma, but growing in follicles. Over time, it was discovered that some encapsulated tumors that were growing in follicles had PTC-like nuclei, and some of them metastasized. And so it was this morphologic shift where the nuclear features basically started to take precedence over architectural features and behavior. So follicular variant of papillary carcinoma was sort of any tumor growing in follicles that was encapsulated or invasive with papillary-like nuclei was called papillary thyroid carcinoma follicular variants. It was sort of discovered that the follicular variant of papillary carcinoma had kind of two subvariants. One was the one on the left that was very infiltrative with this background stromal fibrosis growing in lots of follicles, maybe occasionally papillae, had psammoma bodies, metastasized to lymph nodes. This, as you can see, is very akin to just our classic regular papillary carcinoma. But then there was this one on the right, the non-invasive encapsulated follicular variant of papillary carcinoma that was very well circumscribed, that was composed of follicles. The only thing that separated it from essentially a follicular adenoma was the fact that it had nuclei that were enlarged and wrinkled with chromatin clearing, et cetera. And so it was that tumor that now became NIFP. So formerly, the non-invasive encapsulated follicular variant of PTC ended up becoming NIFP with the isolation of certain criteria, meaning essentially this has to be clearly demarcated or clearly circumscribed without vascular or capsular invasion, with essentially uniformly follicular growth, but with the presence of these atypical nuclei that might otherwise raise the possibility of papillary thyroid carcinoma. Let me just move this aside for a second. So what we found was that, here we go, the NIFP-Ps, right, the non-invasive follicular thyroid neoplasms with papillary-like nuclear atypia are very heavy in RAS mutations, which is very similar to follicular neoplasms, and really only metastasize if they have capsular or vascular invasion, just like follicular carcinomas. And so we were sort of able to say, okay, there is a true papillary carcinoma that grows in lots of follicles, that infiltrates tissue, that has lymph node metastases, that has BRAF mutation, that's still papillary carcinoma. But there's this other tumor, right, that looks more like a follicular neoplasm. So the way I think about NIFP is it is essentially a follicular neoplasm that tends to have nuclei that raise the possibility of papillary because they're enlarged and cleared and overlapping and grooved, et cetera, right? And the only way they're going to metastasize is if they have capsular or vascular invasion. So there are historic cases of follicular variants of papillary that may have fit into today's conceptualization of either the infiltrative follicular variant of PTC, which still remains a carcinoma, or the non-invasive follicular variant of PTC, which may actually be a NIFP. And so review of these morphologies retrospectively, along with concurrent genetic analysis, is basically the only way to differentiate the so-called follicular variants of papillary. NIFT-P today is a surgical disease, right? Like a follicular adenoma. It only requires surgical resection and clinical follow-up. It does not require radioactive iodine. It does not require completion thyroidectomy. It's basically a non-malignant diagnosis, okay? I personally do no longer use the term follicular variant of papillary carcinoma because of the historic issues with the overlap in potential diagnosis. And so I tend to call my lesions sort of papillary thyroid carcinoma, hope you can see this, with extensive follicular growth. So you will not see me diagnose follicular variant of papillary thyroid carcinoma because I think it is fraught with too many problems, and I try to really be descriptive about what I'm seeing. So what NIFT-P, might look like is, here we go. For comparison, a follicular adenoma, right, might have follicles with very round nuclei, but a NIFT-P might have follicles that start to have chromatin clearing or elongated nuclei or grooved nuclei, right? But the capsule and the periphery of this lesion should still remain intact and should still remain circumscribed. So these are the cases here that we will render a diagnosis of essentially NIFT-P, which in my opinion is essentially a follicular neoplasm, i.e. follicular sort of adenoma with nuclear irregularities. And most of these we can prove do have RAS gene mutations. If you find something that is diagnostic of papillary carcinoma like BRAF V600E or some other BRAF fusion, that precludes you from having a diagnosis of NIFT-P and essentially forces you into a papillary carcinoma diagnosis because of what we know about the genetics of these lesions. So the TCGA study on thyroid cancer basically sorted all of these neoplasms into these two relatively mutually exclusive categories of BRAF V600E-like, which resemble classic PTC, and RAS-like, which resemble follicular neoplasms. And it's the NIFT-Ps that sort in the RAS-like genetics. So, I can go on and on and on about this for a while, but that's sort of the bottom line on NIFT-P. Does that make sense? Okay, since it's 9 o'clock and you guys probably have patients to attend to or other things to get to, I can stop. I will provide the recording as well as the PDF for you guys